Welcome to Dr. Amanda Clarke, Heart Health and Cardiology. Nobody told you that the hot flashes keeping you up at night are not just a menopause symptom. Nobody warned you that the night sweats soaking through your sheets at 2 in the morning are not simply a hormonal inconvenience that passes with time. And nobody sat you down and explained clearly, specifically, and honestly that the moment your estrogen begins to decline, your heart enters a new and measurably more dangerous chapter of risk that most American women are completely unprepared for. Here is the truth that the most authoritative cardiovascular research published in 2026 has confirmed beyond any reasonable doubt. Heart disease kills more American women every single year than all cancers combined. 1 in 3 American women will die from cardiovascular disease. And yet, the conversation that every woman going through the menopause transition desperately needs to have about what is happening to her heart right now is still not happening in most doctors' offices across this country with anything close to the urgency and clarity that the science demands. Today, we are going to have that conversation. Every single thing your doctor may not have had time to fully explain about what menopause does to your heart, why it does it, how fast it happens, and most importantly, what you can do about it right now, before the damage accumulates silently beyond the point where it can be easily reversed. Stay with us until the very end, because the final section of this video contains something that the 2026 research has revealed about menopause and heart risk that genuinely surprised even experienced cardiologists, and that every woman watching this needs to hear. Let us start with the number that should stop every American woman cold and reframe everything she thinks she understands about her own health risks. 1 in 39 American women dies from breast cancer each year. 1 in 3 dies from cardiovascular disease. Let that difference settle in for a moment. The condition that receives the least discussion, the least fear, and the least proactive attention from most women in their 40s and 50s is killing them at a rate that is more than 12 times greater than the cancer they fear most. And the menopause transition, those years before, during, and after the final menstrual period, is the biological turning point at which a woman's cardiovascular risk begins accelerating in ways that make the decade between 45 and 55 potentially the most consequential 10 years of her entire cardiovascular life. By the time this video ends, you will understand exactly why that is true. What is happening inside your arteries and your heart during this transition that you cannot see or feel until it is often too late. And what the specific actions are that the 2026 research identifies as most effective for protecting your heart through and after this transition. Let us begin with the biology, because the biology is the key to understanding everything else. For the entire duration of a woman's reproductive years, her body produces a hormone called estrogen that functions in the cardiovascular system as a powerful and multi-layered protector. Estrogen keeps the walls of arteries flexible and responsive. It actively prevents the buildup of plaque inside blood vessels by reducing inflammation in the arterial walls and maintaining the delicate inner lining of blood vessels in a state of healthy function. It supports favorable cholesterol balance by keeping LDL, the harmful cholesterol, lower, and HDL, the protective cholesterol, higher. It helps regulate blood pressure by promoting the dilation of blood vessels. It improves the body's sensitivity to insulin, reducing the risk of blood sugar dysregulation. And it actively reduces the inflammatory processes in blood vessel walls that drive the atherosclerotic disease that causes heart attacks and strokes. This is why women develop cardiovascular disease on average 7 to 10 years later than men. Not because women have stronger hearts by design, because estrogen has been working as a cardiovascular shield for decades. And then menopause begins, and the shield starts to come down. The menopausal transition typically begins in a woman's mid to late 40s, with a period called perimenopause, during which estrogen levels do not decline smoothly and predictably, but rise and fall in an erratic, unpredictable pattern that creates a physiologically stressful environment for the cardiovascular system, even before the final menstrual period arrives. This is one of the most important and most underappreciated findings of recent cardiovascular research. The heart disease risk that most people associate with postmenopausal women actually begins building during perimenopause, when a woman still has periods, still has estrogen, and still feels young enough that heart disease seems like a distant concern. The cardiovascular risk changes that occur during perimenopause are not subtle. LDL cholesterol begins rising. Blood pressure begins trending upward. The distribution of body fat begins shifting from the hips and thighs toward the abdomen, where visceral fat is metabolically active in ways that drive inflammation, insulin resistance, and cardiovascular risk in ways that subcutaneous fat does not. Arterial walls begin thickening and stiffening as the estrogen-supported maintenance of their elastic properties diminishes, and the inflammatory markers in the blood that indicate an arterial environment favorable to plaque development begin rising. All of this is happening, and most women going through perimenopause have no idea. But here is what most people never find out about the menopause transition and heart risk. The hot flashes and night sweats that are the most visible and most discussed symptoms of perimenopause and menopause are not simply temperature regulation problems with no deeper significance. The research now shows clearly that women who experience frequent and severe vasomotor symptoms, the medical term for hot flashes and night sweats, have measurably worse cardiovascular risk profiles than women whose menopausal symptoms are mild. Women with significant hot flashes have been shown to have reduced flow-mediated dilation, which is the ability of arteries to expand appropriately in response to increased blood flow, a key measure of arterial health. They show greater aortic calcification, which is the buildup of calcium deposits in the walls of the body's main artery. They have higher measures of carotid intima media thickness, which is the thickness of the wall of the carotid arteries that carry blood to the brain, and which is one of the most reliable non-invasive indicators of atherosclerotic disease in the body. A hot flash is not just uncomfortable. In a woman with significant cardiovascular risk, a frequent, severe hot flash is a warning signal from a cardiovascular system under increasing stress. And it is being dismissed in most clinical conversations as a quality-of-life issue rather than a heart health alert. Let me tell you about Sandra. She was 49 years old, a middle school teacher from Tennessee who had been experiencing hot flashes and night sweats for almost 2 years. Her primary care doctor had reassured her that her symptoms were normal, that her heart was fine, and that her blood pressure reading of 132/84 was something to monitor but not urgently treat. Sandra felt tired all the time because her night sweats were waking her up at 2 and 3 in the morning. She had gained about 12 pounds in the previous 18 months, most of it around her midsection, which was new for her. Her LDL cholesterol had risen from 108 to 131 in the same period. Each of these changes on its own seemed manageable. Together, they formed a pattern that the research now recognizes clearly as the accelerating cardiovascular risk profile of perimenopause. Sandra did not have a heart attack. But when she finally saw a cardiologist for evaluation of persistent fatigue and occasional heart palpitations at age 51, her arterial age, measured by pulse wave velocity, the clinical test of arterial stiffness, was calculated to be equivalent to a woman of 63, 12 years older than her chronological age. The damage had been accumulating silently through every night of hot flashes, through every pound of visceral fat, through every point of rising LDL, while the conversation remained focused on managing her menopause symptoms rather than protecting her heart. This is the part that genuinely surprises most of my patients. The Framingham Heart Study, one of the longest-running and most authoritative cardiovascular research studies in the world, found that postmenopausal women have 2.6 times the incidence of cardiovascular events compared to premenopausal women of exactly the same age. Not compared to younger women, compared to women of the same age who had not yet gone through menopause. The menopause transition itself, independent of age, produces a 2.6-fold increase in cardiovascular events. And the research is now showing that this acceleration begins not after the final menstrual period, but during the perimenopausal transition that precedes it. The window for intervention, the period when cardiovascular risk management can most powerfully alter the long-term trajectory, is not after menopause. It is during the transition. It is now. For every woman in her 40s and early 50s who is beginning to experience the early signs of perimenopause, the window is open right now, and it will not stay open indefinitely. Now here is something the research actually shows about timing that changes everything. A landmark study published in JAMA Cardiology in March of 2026 followed thousands of women across both Black and white populations and calculated their lifetime risk of coronary heart disease based on the age at which they experienced menopause. Women who went through natural menopause before the age of 40 had a 40% higher lifetime risk of developing coronary heart disease than women who experienced menopause at the typical age. A 40% higher lifetime risk. And the study found that Black women are 3 times more likely than white women to experience premature menopause, meaning they carry a compounded cardiovascular burden that the healthcare system has historically been dramatically inadequate in recognizing and addressing. But the study found something else that matters for every woman watching this, regardless of the age at which menopause occurs. Even at the average age of menopause, the hormonal changes that accompany the transition increase cardiovascular risk in measurable, specific, documented ways. Cholesterol rises, blood pressure rises, body fat redistributes, muscle mass decreases, blood sugar regulation becomes less reliable, arteries stiffen. And the cumulative effect of all of these changes occurring simultaneously in a woman who may be managing a career, a family, aging parents, and the general demands of midlife, without any framework for understanding that her cardiovascular system is undergoing a fundamental transition, produces a risk profile that far too many women are navigating without the information they need to protect themselves. Ask yourself honestly right now, when did your doctor last specifically discuss the cardiovascular implications of your menopausal transition with you? Not your symptoms, not your quality of life, the cardiovascular implications. The cholesterol changes, the blood pressure trends, the arterial stiffening, the visceral fat accumulation. For most women watching this, the honest answer is never. And that gap between what the science now clearly documents about menopause and heart risk and what is actually being communicated to women in routine clinical care is one of the most consequential failures in American women's health today. Let me tell you about Carol. She was 54 years old, a human resources director from Colorado, who described herself as someone who had always been careful about her health. She exercised regularly. She had never smoked. Her weight was in the normal range. She had gone through menopause 2 years earlier without significant symptoms, and it felt that the transition was behind her and that her health trajectory was solid. What Carol did not know was that her LDL cholesterol had risen from 114 before menopause to 147 in the 2 years since. That her blood pressure, which had been consistently in the normal range throughout her 40s, was now consistently running at 138/86. That her fasting blood sugar, which had been 89 before menopause, was now 103, in the pre-diabetes range. Each number on its own was borderline. Together, they told a story that her body had been sending clearly in laboratory values for 2 years, while no one had connected the dots and explained to Carol that the cardiovascular risk changes of menopause had been quietly reshaping her risk profile in ways that required a different and more aggressive response than her premenopausal health habits were providing. Carol's cardiologist told her directly that the 2 years after menopause, during which these changes had accumulated unaddressed, were a critical missed opportunity. That the research was unambiguous about the importance of aggressively managing cardiovascular risk factors in the early postmenopausal period, when the trajectory can still be meaningfully altered. Here is the number that should concern every American woman in this age group. The American Heart Association released a major scientific statement in February of 2026, projecting that 60% of American women will have at least one form of cardiovascular disease by the year 2050. 60%. And the driving forces behind that projection are the very risk factor changes we have been discussing today. Rising hypertension, rising diabetes, rising obesity, and an aging female population moving through the cardiovascular vulnerability of the menopausal transition in a healthcare environment that remains significantly under-equipped to address women's cardiovascular risk with the specificity and urgency it demands. Now here is what the research actually shows about what can be done and why hope is genuinely warranted for every woman watching this, regardless of where she currently stands. The cardiovascular risk acceleration of the menopausal transition is real and documented and consequential. But it is not inevitable destiny. It is a set of specific, measurable, modifiable risk factors operating in a hormonal environment that changes the urgency and intensity of their management. And the research is clear that women who identify and aggressively address those risk factors during the perimenopausal and early postmenopausal window experience dramatically better cardiovascular outcomes than women who do not. The interventions that matter most are not exotic or expensive or available only to a privileged few. They are the same interventions that cardiovascular medicine has always recommended, but applied with a level of specificity, urgency, and frequency that the menopausal transition specifically demands. The first priority is knowing your numbers during the transition, with a frequency that matches the rate at which they are changing. A woman who had her cholesterol checked at 48 and was told it was fine may have an LDL of 150 at 52 without anyone having noticed because no one checked in the interval when the perimenopausal transition was producing its most rapid lipid changes. Annual lipid panels, annual blood pressure assessment, annual fasting glucose measurement, and annual weight and body composition monitoring during the perimenopausal and early postmenopausal years is the minimum that the current evidence base supports for women in this age group. Not every 3 years, every year. Because the changes that are occurring are happening on a timeline that makes annual monitoring the minimum appropriate frequency. The second priority is understanding that the cardiovascular risk changes of menopause require a proactive rather than reactive approach to management. Waiting until blood pressure is high enough to clearly require medication, until LDL is high enough to meet the previous treatment threshold, until blood sugar has crossed into diabetes, is waiting until the damage is already significantly underway. The research supports earlier, more aggressive intervention in women going through the menopausal transition, precisely because the window during which that intervention is most effective is the window immediately surrounding the transition itself. A woman whose blood pressure is trending upward during perimenopause benefits from intensive lifestyle intervention and potentially pharmacological treatment earlier in that trajectory than premenopausal guidelines would suggest, because the cardiovascular environment in which that blood pressure is operating is fundamentally different from the one that existed at 40. But here is what most people never find out about sleep and heart risk during menopause. The night sweats and sleep disruption that accompany the menopausal transition are not only symptoms. They are, according to the most recent research, independent cardiovascular risk factors in their own right. Poor sleep during the menopausal transition has been specifically associated with increased arterial stiffness, increased carotid plaque burden, higher measures of aortic calcification, and higher rates of metabolic syndrome. The clustering of risk factors including abdominal obesity, high blood pressure, elevated triglycerides, low HDL cholesterol, and elevated blood sugar that dramatically amplifies cardiovascular risk. This means that addressing the sleep disruption of menopause is not simply a quality-of-life intervention. It is a cardiovascular intervention. Women who effectively manage the night sweats and sleep disruption of the menopausal transition with the help of their healthcare provider are doing something directly beneficial for their heart health, not just their comfort. The third priority is the conversation about hormone therapy that every woman going through menopause deserves to have with a knowledgeable healthcare provider who is current on the evidence. The question of whether hormone therapy is appropriate for any given individual is genuinely complex, genuinely individual, and genuinely dependent on a woman's specific health history, the timing of the transition, the severity of her symptoms, and her personal values and preferences. What the research does not support is the reflexive avoidance of this conversation that has characterized too much of clinical practice, since an overly broad interpretation of older research caused an entire generation of physicians to treat hormone therapy as uniformly dangerous. The current evidence is more nuanced, more encouraging in specific populations and timing windows, and more clearly supportive of individualized discussion than the conversation most women are actually getting. Every woman in her 40s and early 50s going through the menopausal transition deserves a full, honest, evidence-based discussion of what options exist, what the research actually says about those options, and what the individual risk-benefit calculation looks like for her specific situation. That conversation is not happening often enough, and the cardiovascular consequences of that gap are documented in the statistics we have discussed today. Think about the women in your life right now. Your sister, your closest friend, your mother going through this transition a generation ago without the information we now have. Your daughter who will face this transition in the years ahead. The cardiovascular vulnerability of the menopausal transition is not a personal failing or an inevitable fate. It is a biological reality that responds powerfully to informed, proactive, evidence-based management. The science is clear. The tools exist. The window for the most impactful intervention is the transition itself, and every woman who understands what is happening to her heart during this period and takes it seriously is giving herself something that no medication alone can provide: the power of knowing her own risk and acting on that knowledge while the acting still makes the maximum possible difference. The fourth priority is physical activity specifically targeted to the cardiovascular and metabolic vulnerabilities of the menopausal transition. The research is consistent in showing that both aerobic exercise and resistance training produce specific benefits for postmenopausal cardiovascular health that go beyond what either type of exercise produces in younger premenopausal women. Aerobic exercise reduces the arterial stiffness that accelerates through the menopausal transition. Resistance training preserves the muscle mass that decreases through the transition, and that, when lost, drives the visceral fat accumulation and insulin resistance that elevate cardiovascular risk. A combination of both types of exercise, performed consistently through and after the menopausal transition, produces measurable improvements in cholesterol, blood pressure, blood sugar regulation, body composition, and inflammatory markers. Every one of the cardiovascular risk factors that the menopausal transition is driving in an unfavorable direction. For women who are currently sedentary, the research shows that beginning a consistent program of moderate physical activity during the perimenopausal or early postmenopausal period produces cardiovascular benefit that is visible in laboratory values within weeks to months of beginning. Feeling the heat of a hot flash and thinking it is just menopause is one of the most consequential misconceptions in American women's health. The hot flash is real. The menopause is real. And what is also real, and what we now know with a clarity and specificity that the research of 2026 has powerfully confirmed, is that behind every hot flash, inside every night of disrupted sleep, underneath every point of rising LDL, and every upward tick of blood pressure, and every pound of new visceral fat, the heart is sending a message. It is telling every woman going through this transition that the rules have changed, that the cardiovascular protection she carried through her reproductive years is now diminishing, and that the most important thing she can do for her long-term health, her longevity, and the quality of every year she lives beyond 50 is to hear that message clearly, understand what it means, and take it seriously enough to act before the damage that accumulates silently becomes the emergency that could have been prevented. If this video gave you a genuinely clearer and more complete understanding of what menopause actually does to your heart, why the perimenopausal transition is the most critical window for cardiovascular intervention in a woman's life, and what specific actions the 2026 research identifies as most effective for protecting your heart through this transition, subscribe to Dr. Amanda Clarke and turn on notifications so you never miss a video that could change your health. And drop a comment below answering this question honestly. Did your doctor ever specifically discuss the cardiovascular implications of your menopausal transition with you? Or was this video the first time anyone explained the connection between menopause and heart risk this clearly? Your answer matters, and your story could be exactly what another woman watching needs to hear.